Good afternoon, everyone, and thank you for joining us for this week's National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar. My name is Fiona Robinson, and I'm the series host. I apologize for my voice this week. I'm just getting over a little laryngitis, and I'm afraid I don't sound quite like myself. This webinar is being recorded and will be available to the community on the NBDF website, bleeding.org, shortly after the webinar. In today's webinar, we will learn about unraveling acquired bleeding disorders, insights into secondary effects of immune checkpoint inhibitors. We encourage you to ask any questions you may have today. You can ask your question by using the Q&A feature at the bottom of your Zoom screen at any time during the webinar. We will monitor these questions, and following our speaker's presentation, we will put your questions to them. Today, we are joined by Dr. Bill Archibald, Chief Fellow of the Hematology and Medical Oncology Fellowship Program at the University of Rochester. I'd like to thank Dr. Archibald for joining us today, and I'll turn things over to him now to get us started.
Thank you very much, Fiona. It's my privilege to have been invited to speak at today's Wednesday webinar. And as Fiona mentioned, we are going to talk about some work that the team here at the University of Rochester did on the secondary effects of immune checkpoint inhibitors. I would like to thank our patient whose case inspired this work and who consented to the presentation and publication of his case details in order to further the education of medical professionals, and I have no financial relationships to disclose. So our agenda today, first, we are going to talk about the patient case. Then we are going to chat about identifying acquired bleeding disorders, as these are rare disorders and it can be a challenge to identify these in the general practice setting where these are not often seen. We're going to chat about immune checkpoint inhibitors and their toxicities. We're going to answer the question, are acquired bleeding disorders associated with ICI therapy, which is actually somewhat of an open question still. In our case, we're going to talk about how we treated acquired hemophilia A associated with ICI therapy, as well as the treatment of acquired hemophilia A throughout both ICI associated acquired hemophilia as well as non-ICI associated acquired hemophilia. This work was very hypothesis generating, and as a result, the next steps will be chatted about and the hopes that we have going forward for this research. And then we'll open it up for questions and discussion, and the questions can be submitted through the chat function here on the webinar. So the case. The patient background is that this was an 88-year-old man with no personal or family history of bleeding disorders. He had medical comorbidities that included coronary artery disease with multiple stents in place, hypertrophic obstructive cardiomyopathy, and obstructive sleep apnea. His only autoimmune history was he developed Hashimoto's thyroiditis decades ago and has remained on replacement since. In February of 2021, he was diagnosed with bladder cancer, and he initiated intravesicular BCG, which is a standard treatment for local bladder cancer. Over the next 8 months, he continued on this, and then in December of 2021, his bladder cancer unfortunately became refractory to BCG. He was not felt to be a candidate for systemic cytotoxic chemotherapy, nor a cystectomy due to his comorbidities. And as a result, in April of 2022, pembrolizumab, or our brand name is Keytruda, an anti-PD-1 immune checkpoint inhibitor, was initiated. He received 1 cycle. In May of 2022, as a standard practice, prior to the second cycle of pembrolizumab, he visited with his oncologist, and he was found to have hypotension with 80/40, and he was significantly anemic with a hemoglobin of 7.6 off of a normal baseline. At the clinic visit, he was found to have diffuse ecchymoses. This is his left arm, where you can see that it is quite swollen, as well as has discoloration. This is his right flank with significant ecchymoses, and then his left elbow. He denied any history of trauma, and given the fact that he was hypotensive and anemic, he was admitted to the hospital for further care. So his hospital course was as follows. On hospital day 0 to 2, he received 5 units of packed red blood cells, and unfortunately, his hemoglobin did not respond. On day 3, this raised some red flags, and a complete set of coagulation studies were obtained, whereas INR was 1.1 and his APTT was 75.8, which is dramatically prolonged. A CT scan was performed to investigate for active bleeding, and retroperitoneal active bleeds were found in his retroperitoneal muscle spaces, as you can see here on the 2 slices of the CT scan. As a result, hematology was consulted, and we were faced with a situation of prolonged APTT with a normal INR. The differential for this and most common cause is pre-analytical. Heparin therapy is frequently used in the hospital setting as well as is used in lines, and often samples are contaminated with heparin, and this causes an artifactual prolongation of APTT. We ruled this out and moved on to the next portion of the differential. Individuals with a prolonged APTT with a normal INR without a bleeding disorder can be lupus anticoagulant, which is actually a prothrombotic condition, factor 12 deficiency, which is clinically silent, factor 11, also known as hemophilia C. This has a variable clinical presentation and is not always associated with bleeding. Prekallikrein deficiency and high molecular weight kininogen deficiencies can cause a prolonged APTT with a normal INR. And von Willebrand disease, given its milder phenotype, can cause this situation as well as a result of its effects on factor VIII. If the patient has a bleeding disorder, like our patient, the things to investigate are factor VIII, factor IX, factor 11. As I noted before, factor 11 has a variable clinical presentation, and this can present with bleeding. And then acquired von Willebrand disease, which has a different phenotype of mucocutaneous bleeding and generally is milder than acquired hemophilia. So to further narrow the differential, recall that our APTT was dramatically prolonged and our INR was normal. A mixing study, which is done to identify a factor deficiency versus an inhibitor, was prolonged, indicating the presence of an inhibitor. A factor deficiency on a mixing study would correct. His factor testing yielded a factor VIII activity of less than 1%, indicating a severe hemophilia. The reference range is 59 to 163%. In individuals who develop an inhibitor, the quantification of the inhibitor is done with a Bethesda assay. His Bethesda assay was shown to be 89.6 Bethesda units, indicating the presence of a strong inhibitor. As a result, a diagnosis of acquired factor VIII inhibitor was made, also known as acquired hemophilia A. So what is acquired hemophilia A? So an acquired hemophilia A develops when an inhibitor to endogenous factor VIII prevents normal secondary hemostasis. Factor VIII is a massive molecule. Seen here is actually a structure that has a portion of it deleted. And so the molecule is actually even larger than this depicted here. And those epitopes can be exposed to the immune system, and a loss of self-tolerance can occur. And individuals can develop an inhibitor that affects its function as a result of the immune system creating an inhibitor to this. What's important to know is it presents as spontaneous bleeding with hemorrhages in the soft tissues, large subcutaneous and muscle hematomas, or urologic and gastrointestinal bleeding, of which the patient in our case had hemorrhages in both the soft tissue and hematomas. It is a life-threatening condition with mortality rates reported as high as 50%. The risk factors for developing an acquired hemophilia A include older age, underlying malignancy, and a history of autoimmune disorders. So in our case, what were the diagnostic challenges, and what are the diagnostic challenges for individuals who develop acquired hemophilia A? It is an extremely rare disease. It has an incidence of 1.3 to 1.5 cases per million per year. Internists may not be familiar with the condition as a result of its rarity and the fact that this is often a once-in-a-career diagnosis, if it is ever seen at all, if a person is in general practice. Even as a hematologist in a referral center, we only see a couple of these acquired hemophilias a year. And as noted in the earlier case presentation, it did take until day 3 of his hospital stay in order to identify that he had an acquired hemophilia and before hematology was involved. And this is common in patients who develop acquired hemophilias. Of note, acquired von Willebrand disease is more common. It has an estimated prevalence of 400 per million. It is associated with monoclonal gammopathies, but it has a milder phenotype, and that milder phenotype is typically mucocutaneous bleeding and is not typically as life-threatening as acquired hemophilia. So what are the immune checkpoint inhibitors? Recall that our patient was started on pembrolizumab. Pembrolizumab is one of these PD-1 inhibitors. Immune checkpoint inhibitors in general have revolutionized cancer therapy since the FDA approval of ipilimumab, which is an anti-CTLA-4 antibody in 2011. There's multiple classes now. You can see those named there on the left side of the slide, and other targets are under investigation. The idea of immune checkpoint inhibitors is to take the brakes off the immune system and allow the immune system to recognize cancer as foreign. In the canonical way of thinking about an immune checkpoint inhibitor, a tumor cell can express PD-L1, which causes PD-1 to be engaged and T cells to not initiate cytotoxic programs. If you block either PD-1 or PD-L1, you can facilitate tumor cell death. Now, this is a much simplified diagram of how these work, because tumors don't necessarily need to express these ligands in order for tumor cell death to occur when you take the brakes off the immune system. And it's taking the brakes off the immune system that creates a loss of self-tolerance, and things like factor VIII can be recognized as a foreign molecule by the immune system, and you can develop an acquired hemophilia. What are the immune-related adverse events of immune checkpoint inhibitors? This is a list, and you can see that it involves almost every organ system and every type of problem that can lead to an itis of that organ system. And the mechanism is a loss of self-tolerance and activation of T cells against self-antigens. Most commonly, this is dermatologic with a rash, GI with a colitis, pulmonary with a pneumonitis, or endocrine with hypothyroidism. And they occur in up to 13% of patients receiving ICI monotherapy. And so being aware of immune-related adverse events is essential for oncologists, as well as now both emergency departments, primary care physicians, as well as hospitalists, to be alert for these developing in patients who are treated with immune checkpoint inhibitors. But the question at hand in our case was, are acquired bleeding disorders an immune-related adverse event? They were first reported in a case report in the New England Journal of Medicine in 2011 by Delion et al., reporting on one patient who developed an acquired hemophilia A after ipilimumab therapy. Now, the risk factors for acquired bleeding disorders are much the same as patients who have cancer. Older adults, patients with cancer are frequently older adults and are more at risk for developing spontaneous acquired bleeding disorders. Underlying malignancy is actually a risk factor for developing acquired bleeding disorders, even if not treated with ICI therapy. A history of autoimmune disease, and interestingly, blood transfusion as a result of the exposure to a foreign factor VIII protein in the blood transfusion can result in a major histocompatibility complex class 2 presentation of novel T cell epitopes. And this was asked as a response to this Delion paper as to whether this patient had received a blood transfusion. They had not. So in our case, we were looking at the fact that this was a temporally related, but not related to the onset of cancer. Remember, he developed cancer approximately a year and a half prior to his presentation of an acquired bleeding disorder. He's got no significant autoimmune disease history, and this seems to be an immune-related adverse event as a result of ICI therapy. But in June of 2023, while we were treating this patient, this amazing review article came out by Michael Kroll et al. From the MD Anderson Cancer Center. And this is a great review for any hematologist of the hematologic complications of immune checkpoint inhibitors. And in this paper, they actually mention acquired hemophilia as not having reached a point at which the increase in use of immune checkpoint inhibitors matched the increase in acquired hemophilias. And so they felt that acquired hemophilia may not be a toxicity of immune checkpoint inhibitors as a result of the fact that they weren't seeing an increase in the numbers of acquired hemophilias reported with the use of these drugs. Shortly thereafter, though, this letter to the editor in Hemophilia by Moore et al. Came out, and this was an analysis of the FDA adverse event reporting system. And this was, to my knowledge, the first paper that identified that immune checkpoint inhibitors were related to acquired hemophilia A. And so what their objective in this particular paper was to determine if there was an association between ICI exposure and the development of acquired hemophilia A in the US FDA adverse event reporting system. Now, the US FDA reporting system is a huge database. There's over 17 million adverse events reported in this database. And of that, there were 12 unique reports for acquired hemophilia, 7 with nivolumab, also an anti-PD-1, and essentially the Coke to pembrolizumab's Pepsi, ipilimumab, the anti-CTLA-4 antibody, pembrolizumab, the drug our patient was treated with, in combination ipi-nivo, which is used to enhance the effect in certain cancers. And the reported odds ratios in their disproportionality analysis to look at whether ICI therapy was happening more with or acquired hemophilia was happening more with ICI therapy indicated that all 3 drugs were associated with a statistically significant increase in reporting for acquired hemophilia than would be expected over the background. And so this was the first, to our knowledge, to indicate that immune checkpoint inhibitors were indeed associated with acquired hemophilias. So how severe is ICI-induced acquired hemophilia A? In the same database, all 12 patients were considered serious. 6 of the 12 required hospitalization. 2 of the 12 had life-threatening complications, and 2 deaths were reported among those 12 patients, but it was unknown if those deaths were due to bleeding due to limitations in the database, which is certainly something that should be considered going forward as we continue to study ICI therapy and acquired bleeding disorders. Next, in the fall of 2022, an analysis of the WHO pharmacovigilance database, which includes the FDA database, but includes 120 other countries, was released by Konstantinov et al. And they found that nivolumab was significantly associated with acquired hemophilia A, but it did not find that the other drugs were significantly associated. But given the fact that individuals appear to be developing acquired hemophilia A as a result of immune checkpoint inhibitor therapy in the FDA database, and the temporal relationship in our case, we sought to clarify this question. So we performed a systematic literature review, and what we wanted to find out was whether there were other bleeding disorders beyond acquired hemophilia A. For example, how common is acquired Mount Willebrand disease? Are other factor inhibitors, factor 9, factor 11, being found as patients are treated with these immune checkpoint inhibitors? We wanted to understand the treatment strategies for these. We also wanted to understand the outcomes of patients with ICI therapy associated acquired bleeding disorders. We wanted to understand whether patients were able to resume ICI therapy. In our particular case, this was very important as the patient was not felt to be a candidate for cytotoxic chemotherapy, and ICI therapy was the best therapy for him to control his bladder cancer. So what we found was 6 cases of acquired hemophilia A reported in the literature. There was a variable resolution of the inhibitor between 19 days to 4 months in those patients who did resolve their inhibitor. 2 cases were never resolved. There was 1 case reported of a type 2 acquired Mount Willebrand disease with a very mild phenotype. This patient was observed off ICI therapy and it spontaneously resolved after 6 months. There was 1 case of an acquired factor 5 inhibitor, which was an incidental finding on labs. Nivolumab was discontinued for this patient, and the patient died 4 weeks later of progression of cancer, so it's unknown whether that acquired inhibitor would have resolved on its own. So our case, we had an 88-year-old man who received 1 cycle of pembrolizumab and presented with diffuse ecchymoses, retroperitoneal bleeding, and was diagnosed with an acquired hemophilia A. And so how to treat an acquired hemophilia A associated with ICI therapy? We discontinued ICI therapy, and ASCO guidelines are available for immune checkpoint inhibitor toxicities, and treating clinicians should be aware of these ASCO guidelines because it outlines the general approach based on the grade of toxicity. And this was considered a grade 4 toxicity, and as a result, needed treatment as well as hospitalization. In any patient with acquired hemophilia A, the goal of treatment is to simultaneously treat bleeding and eradicate the inhibitor. So let's talk about how we did that, as well as what the acquired hemophilia community is doing to treat bleeding and eradicate inhibitors. So the first step is to stabilize bleeding. So providing hemostatic support is essential, and typically this is done with either recombinant porcine factor 8 under the brand name Obizar, and UNC has a protocol that was published in Blood Advances in 2020 that is helpful for understanding how to dose and how to use this therapy. There's also recombinant activated human factor 7A, NOVO7. This allows factor 8 to be bypassed and clotting to happen through the other pathway. And as a result, the only disadvantage of that is there's a much increased thrombotic risk versus Obizar. You want to avoid procedures if at all possible. This past year at ASH, there was an excellent education session, and I encourage anyone to look at the ASH education program from 2023 to look at acquired hemophilia. And this diagram is from them. And one of the, many of the current challenges of acquired hemophilia A is inpatient-based care. Patients typically have severe bleeding, require many transfusions. They require these IV bypassing agents like Obizar and NOVO7, and they require combination immunosuppression that leads to high morbidity and mortality. And the hope is that by using emicizumab, and emicizumab, also known as Hemlibra, is a drug that mimics the function of factor 8, but patients won't develop an antibody, or patients with acquired hemophilia A don't have an antibody to it. And this could potentially allow for outpatient care, decreased bleeding, decreased transfusion, decreased use of these bypassing agents, as well as reducing the intensity of immunosuppression. And the goal would be to reduce hospitalization, reduce bleeds, and reduce infections. So emicizumab is revolutionizing the care of acquired hemophilia A, but it's not known yet, and none of the cases that were reported in the literature had used emicizumab to treat acquired hemophilia A associated with immune checkpoint inhibitors. So our case, how we treated it was we do not have Obizar or recombinant porcine factor 8 on formulary at our hospital, but it can be obtained within 24 hours typically. And so NOVO7 was initially initiated at 90 micrograms per kilogram every 4 hours. And then once recombinant porcine factor 8 arrived, we initiated it to a target of 200 with subsequent doses titrated based on targeting a peak factor 8 activity of 200%, trough activity of 100%. After 7 days of appropriate hemostasis, we did reduce the peak target to 100% and the trough target to 50%. Obizar was utilized for a total of 13 days. Next, and simultaneously, you want to eliminate the inhibitor, as patients who have the inhibitor will continue to bleed if this is not eradicated. So there's two main classes of drugs. One is glucocorticoids. These come with the risk of infection and then long-term side effects, including adrenal suppression, osteoporosis, diabetes, and short-term side effects like mood and behavioral changes, and typically are not very well tolerated by older adults. Immunosuppressants, including cyclophosphamide and mycophenolate mofetil, can be utilized. These come with the risk of cytopenia, infections, GI effects, and then in our case, we were particularly concerned about hemorrhagic cystitis as a result of his history of bladder cancer, which is a side effect of cyclophosphamide. Finally is the anti-CD20 antibody rituximab. And rituximab does come with a risk of infusion-related reactions, infections, and viral reactivation. However, it is a drug that can be used successfully to eliminate these inhibitors. So considerations for individual patients, and once again, I thank the ASH education program for this slide because this was an extremely well done slide, is frailty, age, and concomitant disorders, how severe their hemophilia A is, what their bleeding tendency and sequelae is, and then the availability of emicizumab. So in our case, how did we eliminate the inhibitor? We started on prednisone at 1 mg per kg daily and cyclophosphamide at 2 mg per kg. This was continued for 5 days. After 5 days, given the risk of hemorrhagic cystitis, we elected to reduce the cyclophosphamide to 1 mg per kg. Therapy was continued for 2 months until the patient was tapered off of immunosuppressive therapy with no evidence of his inhibitor recurring. Pembrolizumab in his case was permanently discontinued and not felt to be safe to be restarted as a result of the severe and life-threatening complication that he had experienced as a result of the purportedly as a result of the pembrolizumab. His acquired hemophilia A did remain in remission until his death from progressive bladder cancer 10 months after presentation. On this slide, the factor VIII level is depicted in pink, and his inhibitor titer is depicted in green. And you can see that rapidly after initiating immunosuppression, his inhibitor titer began to fall. And then you can see our seesaw pattern as we were dosing Obizar to attempt to keep his factor VIII level in the target range. And so this is a pretty typical, this resolution is faster than most patients experience, but it's required to monitor the inhibitor as well as the level of factor VIII in order to identify when it is safe to stop things like Obizar. So what are the next steps? So one important thing about acquired bleeding disorders is they're very rare. Like I said, it's 1 to 2 per million per year for acquired hemophilia A, and enhanced awareness is needed to prevent diagnostic delays and poor outcomes. And so to the extent that the bleeding disorders community can make people aware of this, it is important to know. I do think there needs to be centralized reporting with variables of interest to hemostasis experts in order to document these cases of acquired hemophilia A associated with ICI therapy. Because I'm particularly interested in addressing the question if can ICI therapy ever be resumed after development of acquired bleeding disorder potentially attributable to ICI therapy. Another open question in this particular area of acquired hemophilia is the role of emicizumab in order to allow patients to have better hemostasis, less transfusions, less product use, as well as reduce immunosuppression. At some point, I think biobanking these specimens would be very helpful to allow for translational studies to understand the basic science behind who develops this complication, why, and what the optimal therapies are. And then an open question for the bleeding disorders community, which I do not have any experience with, and I'm curious if anyone else has had experience with, is individuals with congenital hemophilia A who have undergone immune tolerance induction to eliminate an inhibitor. Is ICI therapy safe for those individuals to take the brakes off the immune system and potentially risk recurrence of the inhibitor? And so those are the next steps that I foresee for this research, and I hope to engage anyone who's interested. Please feel free to email me to talk further about this. I'd like to thank Neil Lachant. Neil Lachant was the attending physician on this case, and he recently passed away. And he was a great mentor and great clinician, and hematology was his passion. And so I wanted to do this presentation in memory of him. And then I'd like to acknowledge our patients. My co-authors, Dr. Lachant, Dr. Coides, and Dr. Rafai, our coagulation our coagulation lab facilitator, Dr. Frank Aqua, Dr. Rajiv Pruthi, and Dr. Clive Zent, my mentors, family, and friends, my fellowship program and co-fellows who are pictured at the right, and the National Bleeding Disorders Foundation for inviting me to present Dr. Lachant and I's work on acquired hemophilia A in the setting of immune checkpoint inhibitors. So now we can open it up for questions and discussion.
Great. Thank you very much, Dr. Archibald. It's really an exciting presentation of your research.
Thank you.
We will go ahead now with our live Q&A. If you have a question for Dr. Archibald, please put it into the Q&A feature at the bottom of your screen, and we will do our best to answer all of your questions. Maybe we can start with a question. So we talked about the development of an acquired bleeding disorder with treatment with the immune checkpoint inhibitors. Does that mean that ICI should not be used to treat cancer in somebody with a bleeding disorder? Is there a likelihood that it could induce an inhibitor in somebody who doesn't have an inhibitor?
That, I believe, is an open question at this point. I would say that in general, treating cancer tends to take precedence when individuals are faced with it. And it should certainly be a multidisciplinary discussion between their bleeding disorders expert as well as their treating oncologist as to the risks and benefits of potentially inducing an inhibitor. Of the patients reported in the literature, none of them had a congenital bleeding disorder. And as a result, it's difficult to answer that question in the absence of any evidence to suggest that the inhibitor will recur for a patient with, or appear for a patient with a congenital bleeding disorder.
Yeah, I guess this really is the challenge of studying rare complications in rare disorders. It's that
Yes.
there's more questions than there are examples, I think.
Yes, indeed.
So another question that we had was about, I mean, as people with hemophilia, particularly, and with bleeding disorders generally, they are living longer than in previous decades, thanks to advances in treatment and care. So I think cancer, is more of a concern in the aging population. Are there any screening guidelines around cancer that are different for people with inherited bleeding disorders than, say, for the general population, or that you would particularly draw attention to?
That is an excellent question. And off the top of my head, I can't name any, but I believe hepatitis, particularly patients who unfortunately were treated prior to the era of universal blood screening. Those patients do have different cancer screening recommendations. So it is certainly important to understand the risk factors at the patient level to develop a personalized screening protocol for them. Like everybody else in the population, staying up to date on things like colonoscopy, which is now or colon cancer screening, which is now recommended at the age of 45 and even younger if there's a first degree relative with colon cancer, along with prostate cancer screening, breast cancer screening, and cervical cancer screening are essential for patients with bleeding disorders as well as the general population.
And I may have missed this, you probably did say, but are there particular cancers that tend to be treated with ICIs versus others?
Yeah, so ICI therapy is mostly used in the solid tumor space. It's revolutionized treatment for lung cancer in particular. It was initially evaluated mostly in melanoma, and we see some outstanding improvements over in previous therapies for solid tumors. In the hematologic disorder space, it's used commonly in Hodgkin lymphoma and other disorders it's been evaluated in, but has not reached the success level that it has in Hodgkin lymphoma.
And is there any correlation between the type of cancer that's being treated, for example, hematologic, and the occurrence of an acquired bleeding disorder as a complication?
So we tried to answer that question in our literature review, and here is the table from our literature review, and you can see that the reported cases generally sort of mirrored the indications for which these drugs are used most frequently. And so non-small cell lung cancer was 1, 2, 3 cases, and melanoma was 3 cases. And urothelial and hypopharyngeal cancer were the other 2 cases. And as a result, it doesn't seem like there's anything beyond the fact that these drugs are being used for these cases. These cancers are the most common cancers that are being treated with these drugs. So a particular cancer does not necessarily put you at more risk of an immune-related adverse event.
Okay, makes sense. And I think you talked quite a bit about acquired hemophilia A. I think you also found some acquired von Willebrands in your literature work. It looks like those are sort of the 2 main acquired bleeding disorders that are coming up as complications with this type of therapeutic. Do you have a theory as to why those in particular might be the ones that respond?
Yeah, so the theory on factor VIII is that because of how large of a molecule it is and how complex its function is, there's basically large numbers of epitopes that are exposed to the immune system that your own immune system has to tolerate. And so if you allow the immune system to not have its typical checkpoints. The fact that factor VIII is such a large molecule with so many different epitopes that are being expressed, so many of which can affect its overall function, there's the opportunity for a loss of self-tolerance due to the size of that molecule, whereas the other molecules in the clotting cascade are smaller and have less epitopes, and therefore it's more likely to develop an acquired hemophilia A rather than the other factor inhibitors.
Well, that's interesting. That's really neat.
No.
Do you know, I'm sure you do know, if the ICIs are used to treat other disorders other than cancer? So are they used in any sort of immune disorders? And are there any cases of acquired bleeding disorders coming up as complications in those therapeutic areas?
As far as I know, the immune checkpoint inhibitors, at least the ones at hand in this presentation, namely the anti-CTLA-4 and anti-PD-1, are not used outside of cancer. However, as it's outside of my specialty, I may be unaware of new indications outside of cancer for these medications.
And I think you mentioned as well that aging is also a risk factor for the development of inhibitors, just generally in bleeding disorders. Do you know if there are screening programs to sort of increase vigilance as people age? Again, as our population of people with bleeding disorders are aging quite happily now in current decades as compared to previously. Do you know, are there initiatives to sort of increase that screening for inhibitors in that sort of second potential wave?
Yeah. Given how rare it is, it would be very difficult to screen for an acquired bleeding disorder in a cost-effective manner. In terms of as individuals with bleeding disorders age, attention to their primary care and their cancer screening is sort of the best way to reduce the risk that they'll ever be exposed to one of these medications, and living a healthy lifestyle, namely not smoking and avoiding known carcinogens, is sort of the best way to protect yourself against having to be exposed to an immune checkpoint inhibitor.
And maybe I can ask a question which is a little bit off the topic of the research that you've been doing, but it is something that is really, I think, of interest to the National Bleeding Disorders Foundation, and that's around workforce development. You're a fellow who's working in oncology and hematology, and there's been discussion about, how do we encourage people to continue, fellows to continue a career path that looks at bleeding disorders, knowing that there are lots of opportunities also to continue in oncology. So you seem like a great candidate to maybe give us some thoughts about how do people make those sorts of decisions? Is there something that can help to draw talented young investigators like yourself towards bleeding disorders?
Yeah, I'll share my story of how I ended up as interested in hemostasis and thrombosis, and then draw some parallels as to how others can get involved in hemostasis and thrombosis and pursue this really intellectually stimulating area of medicine, and one in which there's tremendous value in caring for patients with bleeding disorders. So I started my career as an accountant. Both of my parents are accountants, and my grandmother had some strokes, and I developed an interest in medicine as a result of that. I retrained at a post-bac program and went to medical school here at the University of Rochester. And during medical school, I was first exposed to hematology and oncology, mostly the oncology side of things. And I saw a lot of value in caring for patients with cancer. In residency, I was lucky enough to be on the hematology consult service with a tremendous mentor, Dr. Pruthi at the Mayo Clinic, who just inspired a love of working up thrombosis and hemostasis issues, as well as the lifelong care that you can provide a patient with a bleeding or thrombotic disorder. And I would say that mentorship is incredibly important in developing the workforce. Here at the University of Rochester, I've had many excellent mentors, one of whom is on the call I see in the Q&A. And I feel that mentorship is one of the best ways to get people inspired and focused on bleeding disorders. And ways in which the bleeding disorders community can support that is if there's medical students or residents rotating in bleeding disorders clinic, as a patient, sharing your story can be inspiring and inspire individuals to pursue a career in bleeding disorders, as well as for us clinicians, being available to mentor individuals who may have a spark to feel interested in bleeding disorders is tremendously important. So I chalk it up to mentorship and having great people to follow. And I hope to help individuals who are interested in pursuing a career in bleeding disorders make their way through it like I have, and continue the research and efforts that we have.
Great, thank you. That's really helpful. That certainly does, it certainly aligns with some of the discussions I've heard where the idea, like you were saying, that having that experience and having that mentorship seem to be really key, because it's a fantastic community to work with. I know from my own experience, the bleeding disorders community, once you work with them, you don't want to leave.
Yes.
Working with them. Somebody has asked us if you wouldn't mind putting your slide with your email up, again, because they'd like to get in touch. And I will have to agree with the comment that came in on our Q&A saying this was really an outstanding presentation. And
thank you.
Really appreciate the everything that you shared with us in terms of the research that you're doing and your expertise around it, and then also your own experience. It's an area we don't discuss as much, I think, the acquired bleeding disorders, but so much of it is so relevant, and like I said, the whole community is so interconnected that it's really great to talk about this with you today. So thank you.
Thank you. Unfortunately, I didn't have a slide already prepared with my email, so there is my email if anyone needs it.
Awesome, thank you.
So.
And I guess would it be okay for someone to contact you if they feel like maybe they're seeing the same sorts of things in one of their patients?
Absolutely. And in fact, when we first endeavored on this systematic literature review, we did reach out to hemophilia centers across the country to see if anybody else had experienced this. And so collaboration in this space, especially since it's such a rare complication, is essential to understanding it and improving outcomes. So I would be very open to being contacted.
Fantastic. Yeah, and we will hope that we can get the word out through your webinar here, which we do often have some international participants that attend. So hopefully the word will spread also beyond the US. And we also will make the recording available, of course. So that will be a chance too for people to learn more about this. So this wraps up the questions that we have received. So I want to thank you again, Dr. Archibald, for answering all of those questions and for sharing your expertise and your time with us this afternoon. I'd like to thank everyone in our audience for joining us today as well. This recorded webinar will be available on the NBDF website shortly after the webinar. Please note that the NBDF website has very recently changed from hemophilia.org to bleeding.org. Hemophilia.org does automatically redirect you to bleeding.org, but you may want to update your bookmarks. If you go to the NBDF website under the events tab and select past events, you can find all of the recordings of the Wednesday webinars there. And you can also see the list of upcoming Wednesday webinars. So thank you so much for joining us this afternoon, and have an excellent week.
Thank you. Really appreciate the opportunity.